Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Psychiatric Advance Directives, a promising tool to enhance crisis and recovery care. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Before beginning, I would like to take a quick moment to highlight a few housekeeping items. This presentation is being recorded and it will be available on demand on our website, typically within about 3 to 5 days. Throughout the webinar, we will present poll questions and strongly encourage your participation. When poll questions are presented on your screen, please click on your answer choice and then submit or type a response in the chat box. If you have technical questions, a member of our team will be able to assist you. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at Emory University's Rollins School of Public Health. We are proud to serve the 8 states of HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance throughout Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities throughout the Southeast. We encourage you to visit the Southeast MHTTC website to learn more about our center and upcoming events. I'm now going to turn it over to Dr. Druss so that he can present our speaker.
Thanks so much, Emily. Hi, everyone. So Marvin Swartz is professor and head of the Division of Social and Community Psychiatry at the Duke University School of Medicine and the co-director of the Services Effectiveness Research Program. His research interests include psychiatric advance directives, mental health services for people with serious mental illnesses, mandated community treatment, and outpatient commitment. In collaboration with Jeffrey Swanson, he is developing and delivering a web-based facilitation tool for completing psychiatric advance directives. Dr. Swartz was a member of the John D. and Catherine T. MacArthur Foundation Research Network on mandated community treatment and was the co-PI of the NIMH Clinical Antipsychotic Trials of Intervention Effectiveness, or CATIE study for schizophrenia. So with that, I'll turn it over to Dr. Swartz. It's really wonderful to have you here on such an important topic. Thank you.
Well, thank you very much. It's a pleasure to be here and an honor to talk to you all and have the opportunity to really make the case for why psychiatric advance directives should be part of the conversation in implementing evidence-based practices. The way I got into this is as a practicing psychiatrist and someone who took care of people who had periods of fluctuating capacity, so the times in which they really couldn't make decisions and speak for themselves, that this was a tool that had great promise, at least in our view, as a way to preserve the autonomy of people who do have fluctuating capacity, so have periods of crises in which their thinking isn't clear, and as a corollary to avoid involuntary treatment, which is something that really troubles a lot of people with serious mental illness. So let's get into it, and hopefully you'll find this argument persuasive. So the objectives are to list the potential benefits of psychiatric advance directives, to summarize the origins and rationale. So where did they come from? And discuss some of the approaches to overcoming barriers to implementation of psychiatric advance directives. Oh, excuse me, and no. I have the, hold on a second, I put up the wrong version. Sorry. Okay, despite everyone's good intentions, here we are. So, sorry about that. So we are going to have polling questions, as I said, or as we said at the outset. So first, let's see who's in the audience. So please respond to this query about what your current position is or your role in this. So just respond to the poll here. Okay, let's see. So many of you, so we have a fair number of psychologists, other trainees, administrators, social workers, and a lot of others. Okay, well, I'll address my comments to the others. So let's start with a case example. Ms. Jones is picked up by the police after she's found wandering and mute, wearing sandals and a t-shirt in cold weather. They transport her to a crisis facility. In the crisis facility's electronic health record, there's an indication that Ms. Jones has a psychiatric advance directive. The advance instruction gives information about her history and medication preferences. She also has a healthcare power of attorney, and her sister is her healthcare agent, the person who's serving in that role. The psychiatrist examines Ms. Jones and finds that she's currently lacking capacity based on her inability to attend to his questions, and her statements do not seem to be related to reality. The psychiatrist documents that Ms. Jones is currently incapacitated and writes that in her medical record. He then calls her sister, who gives him further information about what Ms. Jones would want in terms of treatment. The sister comes to the crisis facility and signs paperwork allowing Ms. Jones to be admitted voluntarily to the hospital. Ms. Jones is relieved by the presence of her sister, who she trusts to speak for her, and calmly agrees to hospitalization. So this is an example of a scenario in which a psychiatric advance directive is effectively used. So let's do a little query now on how do you think the PAD helped? So can we put that question up? So just type in how you think it might have helped. Okay, let's see some of the responses. Okay, maybe that one didn't work the way we intended. So let's go on. And I'll say some of the ways in which it helped we'll illustrate in the next several slides. So what are they? Psychiatric advance directives are legal documents that allow persons when of sound mind, and there are air quotes around sound mind because we're gonna have to go back and think about that. And that part, that written instruction, is sort of like a living will, and it's called in the Psychiatric Advance Directive jargon, advance instructions. So it's like a living will, except it's about psychiatric decision making. And then a separate part is called the healthcare power of attorney. In Georgia, that's called a durable power of attorney, and it has different names across different states, but most every state has something like that. And that permits you to authorize another person to make future decisions about mental health care on behalf of the mentally ill person if he or she becomes incapacitated. So two parts, the advance instruction, the healthcare power of attorney. So what are some of the benefits of PADS? And now think back to that case. Well, in that case, it authorized permission of the providers to consult with the family in the role, who were serving in the role of healthcare agents. So all too many times in an emergency or crisis situation, there's some lack of clarity or refusal on the part of the patient to give permission to talk with the family. Now, we could debate whether the provider could speak, but one of the things that the PAD does is it gives a limited waiver of confidentiality and allows the providers to speak to the family or other people about the patient in the situation. So it authorizes permission to speak with both the family and other providers. And that's, as you know, a big barrier to care in some situations in which, say, a patient comes to emergency room or a crisis center where they're not known, there isn't a lot of information on the chart. And this is a way for the providers to rapidly get filled in on the information they need to make decisions. In that regard, it's sort of a précis of the medical record or a crisis plan. So it provides a history and a crisis plan via the advance instructions, but it also authorizes admission by the healthcare agent. So you saw in that case, the healthcare agent was able to go in and, knowing that that was the wishes of the patient, went ahead and signed a voluntary. So that avoided involuntary admission. So these are all important things. It also preserved the wishes of the patient on how she would like her crisis to be managed. So the goals of the advance directive is to ensure that patients are treated according to their wishes, even when they cannot speak for themselves. So all too often what happens in a crisis situation is the patient really isn't in a position to give informed consent. And so people start doing things around them, often in the form of involuntary treatment, to try to address the inability to obtain informed consent. Excuse me. So even when the person's unable to communicate coherently, it provides a mechanism for exchange of clinical information and consent or refusal of treatment. So it is a mechanism for advanced consent. And we'll get into some of the issues around it and some of the controversies about it, but that's what it's intended to do. But it also appoints a proxy decision maker, which sometimes is referred to as a healthcare agent, when a patient's incapacitated. So a patient who, say, has had a debilitating crisis and has recovered and is able to reflect on that experience can set this up as a way to have their wishes honored and their preferences preserved, even at a future point when they may not be able to coherently speak for themselves. So let's talk a little bit about the legal origins. So, where did this come from? And you have to think back to the early 1990s, those of you who were around then or read about that period of time. And in the case of Nancy Krizan, she was a young woman who was in a persistent vegetative state as a result of a car accident. And she was in a hospital in Missouri, and her family requested that she be removed from life-sustaining treatment. She was on a feeding tube, among other things, and the hospital said, well, we don't know about this. We've never confronted this situation in which we've been asked to take a patient off life support. And this went up into the Department of Health in Missouri, and the family pressed their wishes to have her removed from life support and honor her wishes for end of life. And it was sort of a legal impasse in that there was no clear law about when could a patient, or if a patient could at all, end life-sustaining treatment. So this went to the Supreme Court, and in 1990 they said, well, yes, a patient can forego life-sustaining treatment, but we need to see clear and convincing evidence of the patient's wishes in order to withdraw life-sustaining medical treatment. And so they define that as the need for written documentation as evidence of the incapacitated patient's treatment preferences. So this is relatively recent, that the whole idea of structured informed consent and advanced directives came into being. And right on the heels of that, back when Congress enacted laws, they passed the Patient Self-Determination Act of 1991 in order to operationalize the Supreme Court decision. And what the law says is, its intent was to help implement medical advance directives in the end-of-life situation as a living will. So this has all been about end-of-life directives. Now, I'll argue that actually we need to move beyond end-of-life advance directives, because we're going to have cohorts of people who are living with situations in which they do need proxy decision makers. So for example, probably in the next decade, within the decade, one will be able to get some kind of blood test or other scan that will determine the risk of dementia. So say you knew on the basis of a blood test or a scan that you have had a very high probability of dementia and needing assistance in making decisions about your medical care. Well, it would really be good if we started to develop these kinds of living wills that aren't just about end-of-life planning, but are also about how to live in a capacitated state and how your family or loved ones should care for you. So returning to the Patient Self-Determination Act, the idea was to try to implement medical advance directives for end-of-life decision-making. And it said that hospitals that receive federal funds, so Medicare and Medicaid through CMS, that those hospitals had to ask patients if they had an advance directive on admission. And so if any of you have been admitted to the hospital since 1991, likely someone asked you if you had an advance directive. And then the hospital is required to document advance directives and follow them and have written policies for implementing advance directives. Well, in the late 90s, almost a decade after this whole notion of living wills and advance directives came into being, advocates for persons with mental illness began to imagine an adaptation of advance directives for mental health purposes in hopes of strengthening patient self-determination and reducing the use of involuntary commitment. So the thinking was, well, we know that there are people with mental illness who, when they get sick, make decisions or are unable to make decisions that they later regret. Is this a mechanism for people in advance to plan for those kinds of situations so that things are not taken out of their hands or their preferences are not honored? Now, one difference between PADs, Psychiatric Advance Directives, and end-of-life advance directives is that they're generally self-binding. The idea there is that often when people with mental illness are in a crisis, they may contradict their previously expressed wishes in the advance directive. And instead of getting into this type of what's called Ulysses conflict or Ulysses contract, what the PAD does is say, okay, during the period of time in which the person is confused and unable to communicate coherently, the PADs, what's written in the PAD will take preference, and it will be honored over the refusal or the lack of coherence of the patient. So they're self-binding. So that's a little different from medical advance directives, which generally are not binding, in that a person in extremis, in the end of life decision, usually can change their mind, and usually that's honored by the medical professionals. So in the self-binding form of PAD, once incapacitated, the patient can't change his or her mind about treatment preferences. So in my state, in North Carolina, we passed a PAD statute and eventually separated the two provisions into different parts of statute, so that the living will part, the advanced instructions for mental health treatment, is in one part of statute, whereas the healthcare power of attorney is in a consolidated healthcare power of attorney, in which you can appoint a medical or psychiatric or both type of healthcare power of attorney. So how much interest is there in this? Well, you see that since the original advocates started to promulgate this idea of use of advance directives for psychiatric reasons, it has spread gradually across states, such that there's now 27 states that have adopted these separate psychiatric advance directives. So that also begs the question, well, what about the states that don't have this freestanding legislation? Well, in those states, by and large, and with very few exceptions, and maybe no exceptions at this point, you can still construct an advance directive that will take care of psychiatric needs. So, for example, in Georgia, you can put psychiatric decisions into the durable power of attorney and put the same type of instructions there as one would put in the two-part type of advance directive, where you have a separate advance instructions or separate living will, and then a separate healthcare power of attorney. So in Georgia, and I know many of you are from Georgia, you could do it through this durable power of attorney, and that would be honored and work adequately. So let's see another poll. Do patients want to complete PADs? Do you think that patients would care about this? And if you can put up that poll. So do you think patients want to complete PADs? Persons with severe mental illness who've had periods of incapacitation? So either say yes, no, or unsure. Okay, let's see the results. So 55% of you said yes, 12% said no, and 33% said they were unsure. So good response. Let's see what did happen when we asked them. So we did a study with the MacArthur Network on mandated community treatment and went to 4 sites around the country in large clinics serving persons with severe mental illness. So Chicago, Durham, North Carolina, San Francisco, Tampa, and Worcester. And we said, have you completed a mental health advance directive or appointed a healthcare agent for future mental health treatment? And only about 4 to 5% said yes. There was one outlier site at Tampa that had a little bit higher rate of endorsement. So very few people with serious mental illness had some kind of advanced care planning. We then asked the question, would you want to complete a PAD if someone showed you how and helped you do it? And here you see the rate of endorsement went to about 2/3 or 3/4. So 3/4 to 2/3 said, yes, if someone would help me, I'd love to have one of these things. So what you see is a big gap between what people would like and what they have vis-a-vis an advance directive. So, in terms of the responses that we just had to this survey, we were pretty close. And about 2/3 to 3/4 of patients said, yes, they would want one. Well, has that held up, or is this just a theoretical opinion survey? Well, in fact, in the studies we've done, in intervention studies where we offer people facilitation, someone to help them complete them, we have found consistently that if offered help, about 2/3 of patients, about 50% to 2/3 of patients, when offered assistance, and it depends where it is and what type of assistance, but if they're offered a personal facilitator, about 2/3 go on and complete the advanced instruction. So it's pretty close to what this opinion survey said. So why is all this important? Well, as we saw in the vignette, we saw that what a PAD does is it allows families and proxies to speak directly with providers during crises. All too often, the families or significant others are kind of locked out of the crisis because the providers think they can't talk to them because the situation is so dire. But with this advance directive, the families or the proxies can come right in, exchange information, and make decisions themselves during crises. So both in theory and in action, what this does is supports patient autonomy and empowers persons with mental illness in their healthcare in the moment. And we think, and we have demonstrated, that this is a way to reduce involuntary treatment. We think it's important to reduce or avoid involuntary treatment whenever necessary, because so many patients get alienated for treatment because they are involuntarily committed or they're put in police or law enforcement custody. And so this is a mechanism, when well implemented, to avoid all that and reduce police contact with persons in crises so that mental health professionals can care for them. It can also improve continuity care. For example, in a case of a patient who's unknown to the providers, the fact that you have a document that offers a sort of précis of the record in a very condensed form can be of great assistance to that emergency room. So if you have very busy providers who don't have time to go through a full chart review on a patient they don't know, what the advance directive does is offers up, in effect, a crisis plan and puts right in front of them what they can do to help the patient. Another reason why this is important is that the honoring a PAD is a condition of participation in Medicaid and Medicare for treatment facilities. And we'll get into that for a moment, but it's a very important part of the carrot and stick in honoring PADs. And I'll show you that right here. The CMS, some years ago, printed in the Federal Register in the final rules on seclusion and restraint, they said, well, we want to remind people that people have a right to implement and to formulate psychiatric advance directives, and that the standard that is stated in the final rules on seclusion and restraint also supports the patient's right to have a family member or representative of his or her choice and his or her physician notified promptly of the patient's admission. So the CMS reminded the field that advance directives do apply to patients in psychiatric facilities, and that this was an extension in effect of the Patient Self-Determination Act of 1991. So recall, there's two pieces to this. There's the advance instructions and in my state, it's called the Advanced Instructions for Mental Health Treatment. And that's like a living will, documents one's wishes, consent, or refusal of future care. And then there's the healthcare power of attorney, in Georgia called the durable power of attorney. It's called different things in different states. And that appoints another person to make decisions during a crisis. And it allows that the person appointing the healthcare power of attorney can tailor that appointment to meet the needs of the person writing it. So it can have limited or broad powers. In my state, in North Carolina, you can have either or both. In some states, that process involves only one document, the document's consolidated. And in Georgia, where there's only the durable power of attorney statute, you would put both into that one document. So you would instruct the proxy decision maker about what kind of decisions one would wish. So what about the instructional directive? Well, that usually permits the individual, the patient, to plan for, consent to, or refuse anything that they might specify in a treatment plan. Hospital admission or refusal, for example, most typically, which hospital would the person wish to go to, medications, even ECT, or other treatments. Now, these directives, though, and this is important to remember, only takes in effect in the event the individual loses the ability to make decisions, is deemed incapable. So until someone examines the patient and says this person lacks decision-making capacity, the instructional directive may be informative, but it has no legal power. So how do you make these things? Well, any adult of sound mind, and I have air quotes around that, can make one signed in the presence of two witnesses, and the witnesses can't have any type of conflict of interest. So they can't be a relative, a doctor, a staff of the healthcare facility. Must be notarized and then presented to the doctor and other just mental health treatment providers, put on the record. So what is this about a sound mind? And is that the standard of judging whether a person is capable of writing the advanced instruction? And in fact, the answer is yes, that is the standard for documents like this. So like wills, so on and so forth, where the person seeks out witnesses, and the role of the witness is to attest that the person appears to be of sound mind. To some people, that doesn't seem adequate, that they would like a competency or capacity assessment right before the instructional directive is written, or they would wish that in advance of someone writing a will, but that's not practical, and it's not the way these legal documents work. So it's the job of the witness to judge whether the person can or can't create one of these documents. So what should the doctor or the staff do with the instructional directive? Well, make it part of the medical record, act in accordance with the instructional directive when the patient is deemed incapable, and we'll get into that in a minute, and must notify or may notify other providers to follow the instructional directive. So let's get into this incapacity issue. This is the definition in North Carolina, but it's very similar to other states. What incapable means is that in the opinion of a physician or eligible psychologist, the person currently lacks sufficient understanding or capacity to make and communicate mental health treatment decisions. So despite the fact that that sounds a little circular, the gist of it is this is a bedside determination. So it's a clinical determination by a physician or psychologist that the person is unable to understand the treatment decision or communicate about the treatment decision to the providers. Now, to some of you, this might sound like a adjudication of incompetency, and it isn't, because this does not involve the court. This is a bedside determination in which it's written in the record, and at that point forward, until someone reverses it, the patient should be deemed incapable of making any decisions about their mental health treatment, and maybe their healthcare treatment, depending on how it's framed. So this is not an adjudication of incompetency, but you could analogize that it's like an emergent form of guardianship, because in fact, during the period of incapacity, the proxy serves as a form of emergency guardian, is an analogy, not literally, but it's similar. So some clinicians get concerned about this. They say, well, what is going to happen if a patient writes stuff in their advanced instruction that makes no sense or is, a product of a psychotic episode? Well, the laws in most states give great deference to the clinician and their need to make cogent treatment decisions. So the clinician may disregard instructions, and this is similar in most states, if the instructions aren't consistent with generally accepted community practice standards. So for example, if the patient says, well, when I get psychotic, I want to be treated with ginkgo. Well, most physicians wouldn't think that's an adequate treatment for psychosis and could simply document in the record that they can't give the patient ginkgo as the sole treatment or as monotherapy for psychosis. And so would document that in the record and not do it. Now, another scenario that comes up not infrequently is that the patient makes a request that's not feasible and not available. So for example, they put down that they would like to go to a hospital that has no empty beds. Well, that's not feasible. And what the provider does there is says, well, there isn't a bed available, or for some other reason they can't transfer the patient there. And then try to carry on with honoring the advance directive absent that one decision. Now, it can also be overridden if it would interfere with treating an emergency, or can be overridden by involuntary inpatient commitment, or conflicts with any law. But the key take home here, I think, is if a clinicians that are concerned that their autonomy or locus of control is going to be trumped by the patient, they really don't have, by the advance directive, they really don't have big worries in that department. So let's briefly talk about how the healthcare power of attorney works. It allows a patient to appoint someone to make treatment decisions when the patient's incapable or incompetent. So this is a big idea and surprises some people, because what it's saying is that when a patient does this and appoints a family member or friend or loved one to serve in this capacity, that person can make any decision that the patient could have made for themselves if they were not incapacitated. And any capable adult may execute it. And in North Carolina, as I pointed out, it's actually 2 little pieces of law, a statute, but the idea is the same nonetheless. So who can fill that role? Any competent adult 18 or older, usually the individual to serve in that capacity usually can't be providing healthcare to the consumer, so you can't, or the patient. You can't appoint your doctor as the healthcare agent. And we encourage people to offer up several people to serve, because when a crisis happens, it may be inconvenient time, or the person you wish to be in this role is out of town or just unavailable for some reason. So it makes sense to appoint several people in succession. So we usually ask people to try to come up with 3 names of people they trust and who might be available. So for some people with serious mental illness, that's a barrier to identify people they would trust to make decisions for them. And for some people, their social networks are so constrained by their illness that this can be a barrier, but you can still do the instructional directive without a healthcare power of attorney. Again, it takes effect when the person's found to be incapable and continues during a period of incapacity. And it has to be in writing. Now, one point I want to make here is all too often physicians sort of gloss over the process of informed consent. And I call this the right to be deemed incapable. If I were a person with severe mental illness and I wanted to avoid a crisis in which all my decision-making was taken out of my hands, I would want the discerning physician to examine me carefully, and if I'm incapable, to exercise that clause to deem me incapable so that these doctrines could take over, so these documents could take over. But all too often, clinicians only question whether someone is capable or competent when the patient disagrees with them. So, if you go to our consult service at Duke, what you see is that a lot of the consults for assessment of competency or capacity have to do with a disagreement with the physician. And all too often, unfortunately, there are times when informed consent is taken from a person who really doesn't have the capacity to make a good decision and to examine the risks and benefits of the decision. And the treatment team sort of glosses over that because the patient's not disagreeing. So I think it's important for us to look at our processes for informed consent and make sure that we only take consent from people who truly have the capacity to give informed consent. So what can the healthcare power of attorney do? Well, he or she can make whatever treatment decisions the patient could usually make for themselves. Now, there are caveats here, and these are very important. Unless the patient limits the authority of the healthcare power of attorney. That's important because, say, a patient has different relationships with different people, and so the patient says, well, I want my mom to make any medical decisions, but I really want my sister to make my psychiatric decisions. You can tailor these documents so that different people have different powers, or you can limit the powers of that person. And in our hands, when we've done this in intervention studies, what we found is the most common thing that people do not want to delegate in terms of decision-making authority is the decision about electroconvulsive treatment. And that may be that very few people actually, if they haven't had ECT, have been informed about it or thought about it. But many times, the patient limits the authority of the healthcare power of attorney to consent to electroconvulsive treatment. But there are other issues. Because the healthcare power of attorney is so broad, people often do want to limit their authority so they're comfortable with the authority they give to the healthcare power of attorney. So the big question in our minds then is, why aren't psychiatric advance directives? Since I've convinced you, I hope, that these are great ideas, why aren't they in the mainstream of mental health care yet? Well, one reason is I think we haven't really made the case and sold the idea to the different stakeholders affected. So haven't sold it to patients or consumers, haven't sold it to clinicians because they still think it's going to limit their authority, haven't sold it to families. And so we need to do much more focused advocacy for these things. You can also, recognize that medical advance directives are maybe a decade ahead, but they're still emerging in common practice. And 10 years ago, medical advance directives were not a big part of the conversation and hadn't gotten into the mainstream. So an optimistic view would be that we're just a little bit behind medical advance directives. Another reason why, at least arguably, they're not in the mainstream and not everyone has them, is that about only half the states, 27 states, have these specific laws. Now, another barrier that we've seen quite a bit of is that they're difficult to complete for some patients. So often the forms, although you don't have to use those specific forms, often the forms that are offered up have been written in a way that they're not accessible to people who don't know about the law or have limited health literacy. And they have to be translated, or people need some assistance in understanding how these things work. And that help in completing advanced directives, which we saw most people would like, may not always be available. Now, we have a project underway in North Carolina in which we're training peer support specialists and NAMI members to be available. We train them in facilitation in a method we've developed, and they're available as a resource network to people who would like to complete them. The other piece is that health systems and providers need guidance in putting PADs into practice, how to do them, how to get people up to speed. And we need to do more education about PADs and putting assessment of capacity into clinical practice so that providers think immediately about what does this person have the capacity to give informed consent, and if not, what are the next steps? So the next poll question is, what do you think some of the barriers are where you live to consumer and patient barriers to advance consent? So give some thought to that, what you think some of the barriers are. And let's go on. Okay, can we see that again?
Dr. Swartz, a few people have weighed in on the chat box.
Yeah.
I'll just read a few. Education was listed as one barrier. Lack of knowledge, so a language barrier. Family members of patients may be opposed. Consumers do not understand the PAD.
Okay, great. And those are all things that do come up. And they can be conflict. And we've seen this in our work with PADs, that sometimes the patient and the family aren't on the same page about what they would wish to put in a PAD. And there's the fear by some patients that the families want to use this to control them. Now, they don't have to appoint the family to do this, and it can be someone else that is delegated the authority to do this. But that's why a lot of education needs to be put out there so that people understand and see the value of it, and not as a object of conflict. So those are great insights. Thank you. So now the question, would you use it for a voluntary admission? So like in the case of that we showed you a few minutes ago, would you use a PAD for a voluntary admission? Say you're in the emergency room, you have a patient like the one we displayed. Would you go ahead and do that, or would you be reluctant to? So the responses are yes, no, or unsure. Okay, let's see the answers. Great. So 70% of you said yes, and 27% said they were unsure, 3%, 2% no. So that's a pretty good showing. Some people would say, well, what's going to happen when I call up risk management in my facility? What are they going to say? And one of the reasons we need to get much more experience with these things is so that the risk managers, the attorneys and risk managers, get familiarity with these ideas so that they can honor them when they come up. So I'm glad to see so many of you would consider using this as a mechanism for voluntary admission. So we talked a little bit about the Ulysses contract and the controversy among ethicists. So think back to your 8th grade Greek mythology and try to recall the myth of Ulysses. So Ulysses was on a 10-year voyage back to Ithaca from the Trojan War. And he was warned by Circe to take precautions if he didn't want to wreck his ship. And the way that would happen is, as depicted in this slide, the sirens were these sort of devilish mermaids who would distract the sailors and in that distraction veer them off course and they would wreck their ship. And Circe was warning Ulysses that he didn't, if you want to go home and see your family and see your kids, you haven't seen them for 10 years, you need to avoid the sirens. So Ulysses accordingly ordered his men to stop their ears with beeswax and bind him to the mast. So you see him bound here to the mast. And instructed them that if he gestured to be set free, they would still stick to their agreement and bind him firmer still. So this dilemma in ethics is called the Ulysses contract because ethicists question which statement by Ulysses represents his true self and his true wishes. Is it the Ulysses who says, no matter what, keep on course, don't be guided by the sirens or the sirens' call? Or the Ulysses later, once influenced by the sirens, who says, no, let's follow the sirens. So which represents the authentic wish of the patient? Now, in our use of the contract and the bindingness of our advance directives in mental health purposes, we are saying that the patient who objects in the present in crisis, being in capacity, doesn't really represent the true wishes of the patient because they've been expressed previously during a competent or capacitated state. But ethicists will argue about these things, and this is the gist of the argument. This is controversial enough that in the state of Washington, when they recently revisited their advance directives law in mental health, they made it an option for a patient to have a binding or non-binding advance directive in mental health. So you can make it binding and in effect set up a Ulysses contract or not make it binding in that statute. So we have done research, as I mentioned before, in which we developed a facilitation technique so that people can help individuals with severe mental illness execute an advance directive. And so we used research assistants trained in working with this population in how to do the facilitation. It takes about an hour and a half, probably closer to an hour and a half. And we showed that about 2/3 of patients, when offered this assistance, will do it, and those who were just given a brochure on how to do it did not do it. So maybe 2 or 3% did it. So we saw that this research assistants can do it, and then later in other studies, we showed that clinicians can do it with the same fidelity to the process. Peer support specialists can do it, and now we've also shown that family members of persons with mental illness can do it as well. We wouldn't recommend that the family members do it for their own family members. So to give you a graphic reason why you want them facilitated is that when we were looking around in our study for someone who had done it on their own, this was an example. And so this patient had created their own advance directive, but if you look at it, it's really hard to read. It has, you can't see it that well, but it has all kinds of instructions that are unlikely to be followed. and in general is not something that a busy emergency room physician would pick up and follow. In our hands, they look something like this, although now we type them, in which we make the clear rationale for why the person wants, say, Zyprexa for their next episode versus lithium or Tegretol. So we try to make clear why the person expresses their preferences. And so we've also done this with peer support specialists and clinicians on assertive community teams. And just to summarize the research that we've done across these studies trying to implement advanced directives, as I've shown you, there's a large latent demand for psychiatric advance directives, but pretty low completion rate among public mental health consumers in the US. In fact, most of the patients we know in North Carolina who've done it have done it in our hands in one of our studies. There are significant barriers to PAD completion, as I've talked about, but we have shown that structured facilitation can overcome most of those barriers, and that completed PADs tend to contain very useful information that comports with clinical practice standards that the patient's pleased with, and are feasible. Now, you might say, well, say a patient wants something that isn't feasible. Well, what our facilitators are trained to do is, in effect, do some reality testing. So I'll give you an example. We had a patient who said, when I go to the emergency room, I want to smoke. So the facilitator said, you know, that might be something that you would want, but in reality, I don't know an emergency room that would permit that. So while you could put that down, and I'm happy to help you put that down, you're going to be pretty disappointed because most emergency rooms cannot or will not honor that. And so you're going to be disappointed in your PAD, and you're going to think that it isn't really helping you. So let's try to come up with a PAD that, while it might be a compromise in terms of some of your wishes, it represents a feasible plan for you to be treated according to your wishes in a crisis. So we found that even though PADs are designed legally to determine treatment during incapacitating crises, they can also have indirect benefit. And we found that people who do them feel more trust in their providers, they're more engaged in treatment. And we also found that PADs can have short-term benefits by increasing the consumer's sense of autonomy in their working alliance with clinicians. And we've also shown that PADs can help prevent crises and reduce the use of coercion when a crisis does occur. Now, implementing them can be a challenge, and we need to have system-wide implementations. And so we work with health systems to try to sell them on an implementation plan for their system. And we also have increasingly used peer support specialists to facilitate advanced directives, both on ACT teams and also in other settings. Now, as to the question of where you store them, in North Carolina, we have a repository for advanced care planning on the Secretary of State's website. This used to be a very important place for people to put their advanced directives, and then they could be accessed 24 hours a day, 7 days a week. But by and large, this has been eclipsed by electronic repositories within electronic records. So for example, if you're in a health system that uses Epic, Epic communicates across facilities. So as long as it's in there, a patient in effect could have their advanced instructions visible to any Epic customer. And similarly, you can put it in other electronic records, and so it's very accessible, although these registries still have an important role. Now, if you want to see more information about PADs and learn more about it, we operate a website called the National Resource Center on Psychiatric Advance Directives, and you can see the links there. The URL is it actually works just to put nrc/pad.org. You can also find good information at NAMI websites, Mental Health America Advance instruction sites, the Crisis Navigation Product. All of these are good sites, as well as the Bazelon Project. As Bazelon Center for Law has terrific information. So all of these sites are good places to go. The last thing I want to mention is that now there is an app, and the APA through the SMI Advisor, which is sponsored by SAMHSA, has recently put out a mobile app so that you can put into this app, it queries you on the type of decisions that I've talked about, and you can then put into the app those decisions, store it, and then get it witnessed and notarized. So it walks you through how to do an advance directive and healthcare power of attorney. So this is a brand new app just out from the SMI Advisor, and I encourage you to go in there. It's, if you Google SMI Advisor and then go to PAD app, you'll get this app. The app is actually in the, as you see in the slide, is in the App Store or in Google Play, where you can download it either for the iPhone or an Android device. So this is a great new resource. It's so new that we haven't seen how it's being put into use and whether people still require help. In the application we've been developing in North Carolina, we're designing it as a way to structure the conversation with a person who will help them. But we need to see research on how best to do this. And this is a great start from the SMI Advisor. This is just a little plug for that Crisis Navigation Project, where we're training people to be resources for people who want to create advanced directives in North Carolina. And let me stop there for discussion and questions. I want to thank everybody for participating and answering the polls and listening. So let me open it up there.
All right, thank you so much, Dr. Swartz. Unfortunately, we are over time, so we are not going to be able to do any question and answers today. But I did want to ask and see if you had any closing comments before we go to the evaluation portion. Any last minute thoughts to leave our participants with?
No, just thanks for the opportunity. Sorry I ran a little bit long. And, you know, you have my email there, marvin.swartz@duke.edu. So feel free to ask me any questions if there are follow-up questions. So thanks for your attention.
Yeah, no problem at all. Thank you so much for this fantastic presentation. Just to reiterate, I saw it was put in the chat, but just to remind everybody, this recording and the presentation slides will be available on our Southeast MHTTC website in a couple of days, so you can access these very helpful slides and the resources there. So just to round out today's presentation, the Southeast MHTTC would like to thank you for your participation in today's event. We value your feedback and invite you to evaluate our event. Please complete a brief SAMHSA required survey by visiting the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events like this one. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you will also have the opportunity to download a certificate of attendance for your records if you need it. Please allow about 5 to 10 seconds for your browser to redirect you. Again, our center would like to thank Dr. Swartz for this wonderful presentation and to all of you for your participation and feedback. We hope you will join us for future events. Please visit our website to learn more, and that will conclude today's webinar. Thank you again.